in patients where you have a confirmation, you really want to reduce morbidity and mortality and minimize transmission. That's why triaging the patients is very, very important in order to prevent transmission to healthcare workers or other patients. But also contact tracing will help, because if you are able to trace all contacts of all confirmed people, then you're able to cut the chain of transmission. Patient education on cough hygiene continues, and all the stuff we talked earlier on, they apply to those that have confirmed disease. Now, in terms of triaging, you really want to know, assess severity. And this really is about saturation, very, very important, as well as heart rate and all that. It's important. Now, in terms of early supportive therapy, oxygen is probably something that will save most lives. Very, very important. But also think about fluid management, conservative fluid management, not aggressive. You might create a problem. We discussed empiric treatment. Someone with fever, very, very bad fever, and they're coughing a lot, you might want to give them something to relieve them. But more important, close monitoring of such patients in the hospital is very, very important. If you give oxygen, these are the various ways that you could use. Either use a nasal cannula, face mask, or face mask with reservoir. So depending on the method you use, the quantity of oxygen will differ. But I think the healthcare workers know this very, very well, those who work with these gadgets. But what I need to say one more time is that this intervention is the one that will save most lives. Now, in terms of specific therapies, corticosteroids are not to be used routinely. There's no evidence from randomized controlled trials on all the things that we've had, all these antiretrovirals, chloroquines, and all that. So if doctors want to use that, they need to get information on these programs that are going to be put in place, these research programs, so that everything is monitored appropriately. So where possible, if you know in any of your provinces that there's a clinical trial, you could try and link up with them so that you get your patients registered, or else you use the monitored emergency use of unregistered interventions framework. So this is a framework that is detailed here. I'm not going to waste a lot of time on this, but just to say that when you use unregistered drugs, you need a patient consent form, you need ethics approval prior to use of that, you need to keep data, appropriate data, so that you're able to communicate with other people, because you're trying to build evidence, and if you don't have good data, there will never be any evidence out of such a process. The other thing around the ACE inhibitors, there have been speculations around this. Should they not be used? Should they be changed? And none of these speculations are correct. Your ACE inhibitors, your non-steroidal anti-inflammatories should be used. There is no evidence that warrant discontinuation of these agents. Management of hypoxemic respiratory failure is critical. Two things here: oxygen that we discussed earlier on, but also one need to look at high flow nasal oxygen or non-invasive ventilation. Of course, if it gets worse, then you might need invasive ventilation. I think that one is more advanced. I would urge that not anyone really tries it if they're not well trained. Um, Maybe the other training opportunity I see here for medical doctors will be a course on ventilation, because it's not a child's play to connect a patient on a ventilator and ICU. But this course is really looking at your oxygen administration using a nasal cannula or face mask in casualty or in a general ward, internal medicine ward. Contraindication for high flow nasal oxygen hypercapnia and all that. So this is very important when you reach all these, when you get these conditions, you need to not use that. It's very, very important. When you intubate your patients, if there's a need to intubate, transfer them to units with good knowledge and good equipment to keep these patients under ventilations. It is very, very important to monitor such patients. And I will not go through all the details, but it's critical that the patients get poorly ventilated in the hands of doctors and nurses who understand how to provide sedation and how to connect the equipment, and make sure you get your things work in your hospital, because if load shedding come back and you have a patient on a ventilator, is a challenge. You need a working generator, a functional generator in that facility. So this is a specialized area. I will not say much, but it's just to highlight the doctors to say you're going to need more information, more education, more training on these things if you start getting a lot of patients who are needing ventilations. And the key principles are here for those who will really need them. I'm not going to elaborate on this. These are things that we'll discuss when the need arise. But again, refer if you don't have any of these devices, if you don't have proper environment to sedate your patient, if you don't have a proper ventilator, if you don't have a ventilator that has been maintained, it works appropriately. And when you connect, you should also know when to disconnect. It is very important. The isolation is also important. If someone was asked to isolate themselves, at some point they should de-isolate themselves 14 days after the onset of symptoms if they had a mild disease, and 14 days after achieving clinical stability for those with moderate to severe infection. So the duration is very, very important. But remember, the duration of viral shedding can be longer than even 2 weeks. Where the discussion on in terms of those who are still positive after they've been declared recovered. And the NICD opinion I got was that we should do a test once for diagnosis, and a follow-up test should be done in selected cases. That maybe somebody's a teacher, they're going to face a lot of children at school. We need to know. We need to try and test more than once, or maybe a healthcare worker, but we shouldn't do a second test as a routine, because the problem with these molecular tests, which is not new, even for drug-resistant TB or tuberculosis in general, we have this problem with molecular technology. It could remain positive even after your patient is cured and non-infectious. So this is a space to watch, and we wait until we get more information. We shall come back to you. But this is a side effect of or a challenge linked to all molecular tests. That is why, for example, for drug-resistant TB, we diagnose with EXPERT, which is a molecular test, but we follow up with microscopy and what to call simple microscope and culture. That's what we use for follow-up. But for coronavirus, it's still new. We are learning. We don't know how is this going to unfold. So, in a nutshell, colleagues, this is how you de-isolate for asymptomatic patients who are going to be diagnosed in the private sector. You de-isolate 14 days after initial positive test. For mild cases, it will be 14 days after symptom onset, and 14 days after clinical stability for the severe cases. This will mean that, for example, if someone was put under ventilation, you will then wait till you count 14 days from the time that they're disconnected from ventilation, not from the time of diagnosis.